All right, guys. Well, welcome to the last TBL day of Bio 140. This section is the end of the urinary system and really bringing together some components from the respiratory system, urinary system, all about fluid balance, clearance, and pH balance in the body. So let's start off with just a basic breakdown of where all the water in our body is. Okay, so first of all, our total body water is right around 40 liters. Okay, this makes up about 60% of our body weight. Okay, so that idea that we're 2/3 water weight is pretty close. Okay, and then of that total body water of 40 liters, about 25 of those liters is inside of cells, and only about, and then about 15 of those liters is outside of cells. Okay, so we have much more fluid inside of cells than we do outside. So inside the cells, that 25 liters is 40% of our total body weight, and then that 15 liters is 20% of our total body weight outside of cells. Okay, and then if we break down the components of the extracellular fluid, as shown here, we have about 12 liters of interstitial fluid, so that's the space not in cells, not in blood vessels, but between those is that third space where edema occurs. That is 80% of our extracellular fluid. Okay, and then the last bit is our plasma volume. Plasma volume, we have about 3 liters of that, and that's 20% of our extracellular fluid. So that's pretty much what the breakdown of the total body water looks like. So how do we control this total body water? And we need to keep things quite precise as far as where they are. But we need to lose, every day we're required to lose water for multiple reasons. Okay, so water loss is obligatory, meaning that we have to do it. Okay, so we have to do it because we have to get rid of urea, which is our nitrogenous waste product from breaking down protein. Okay. When we break down protein, we have nitrogenous waste as well as nucleic acids. Both of those things lead to nitrogenous waste, and we got to get rid of that urea. Feces needs to have water in it, so we're not constipated. Temperature regulation requires water loss via sweating, and then the air in our lungs must be moistened. Okay, so there's just 4 examples of where so when we breathe out, we lose water. Okay, so there's 4 examples of where and why we lose water every day. Okay, so the big kind of key point as far as how we regulate how much water we lose is all about regulating urine volume, and we talked about that in the last set of notes with the kidneys. That has a lot to do with ADH and the whole renin-angiotensin-aldosterone system. So we're not going to talk about that more this time, but we're going to talk more about some calculations related to this. So we'll get there in a second. So what about regulating how much fluid comes in? So fluid intake regulation. First of all, this is really regulated by our thirst, right? So thirst is controlled by the hypothalamus in the brain. Okay. ADH is going to be a hormone that stimulates thirst, right? So ADH is very important with that. And then the sensation of having a dry mouth, that stimulates thirst as well. So as soon as we get water in the mouth, that inhibits our thirst. Yeah, and so then greater inhibition occurs when we actually distend our intestinal walls. Okay, and so we actually have stretch receptors in the walls of our intestines that are sensing this, and the more stretched out they are, the less thirsty we are. The only kind of interesting thing here is as soon as water gets in the mouth, our thirst is quenched. Okay, and so this prevents too much fluid intake. Right, so this causes us to not be thirsty before we actually get the water into the blood. So it's a little bit about that. Figure 25.5 in your book shows a little more on that. As far as ion balance goes, both sodium and potassium are very important. Again, as we've talked about before, sodium is a primary determinant of tonicity because it's the primary ion of the extracellular space. Okay, it's regulated by the proximal tubule, right? Because most of it is reabsorbed. Okay, the proximal tubule brings almost all of it back. After the amount of fluid that gets into the kidneys, most of that comes back there, right at the proximal tubule, and the sodium comes back with it. The distal tubule can kind of fine-tune the amount that gets reabsorbed, and aldosterone is key for causing more of this to happen. The major cation of the intracellular space is potassium, and proximal tubule, the sodium and potassium come back together, and then in the distal tubule, they go the opposite directions. Sodium comes in and potassium goes out in levels of high aldosterone, and that's what we see here. So high aldosterone leads to potassium excretion and sodium reabsorption. Yeah, so that's a little bit about how those ions are controlled. Okay, so I want you to just take a minute here, do a little summary of what we just talked about. What are the sources of water loss? How do we regulate urine volume? What regulates fluid intake? Okay, filling in those. Which ion determines tonicity? Which ions are made in ion inside of cells? And then which hormone is primarily responsible for ion balance? All right, take a minute and do that. And then you can pause it, and then we'll move on here to doing some calculations. So this is another thing that you will need a calculator for when we get to the final exam. Renal clearance is really a medical test used to determine how well, will determine a couple things. It can be used to determine how well the kidneys are functioning, but really also to determine how a certain substance is handled in the body. Okay, so the definition of it is the volume of plasma from which a substance is completely cleared by the kidneys per unit of time, and usually used in a minute. Okay, so in order to calculate this, we need to know the amount of substance in the plasma, okay, as well as the amount in the urine and the urine formation rate. Okay, so RC is renal clearance, and we have those three factors here. U is the concentration of substance in the urine. V is the flow rate of urine formation, and then P is the concentration of the substance in the plasma. So there's really three different options when we calculate a renal clearance of a substance. If renal clearance is equal to glomerular filtration rate, that's one option. Second option would be renal clearance is less than glomerular filtration rate. The third option would be renal clearance is greater than glomerular filtration rate. Okay, so if it's the first option, what this means is it's freely filtered, meaning it goes into the urine just with the rest of the plasma. We don't secrete it, meaning we don't add more of it to the urine as it passes through the kidneys, but we also don't bring it back. Okay, so the same amount that went in right there at Bowman's capsule and with the glomerulus, that amount stayed in there. We didn't add any more, and we didn't bring it back. So there's a few examples of this. Inulin, creatinine, both of these are good for calculating kidney function because these tell us what our GFR is. Okay, glomerular filtration rate is a very important number for detecting kidney function. So if we can use these two substances to actually tell us what our GFR is, because we know they're freely filtered, not secreted, and not reabsorbed. Okay. On the other end of things, if renal clearance is less than GFR, like the second example here, what that means is it's freely filtered, it goes into the urine, but then we bring some of it back, right? We bring it back into the body because the amount that ends up in the urine is actually less than the glomerular filtration rate. So some examples of this are things that we'd want to bring back, like sodium, glucose, amino acids. We wouldn't want those things to be lost, so we got to bring them back. Okay, and then the last option is if renal clearance is greater than GFR. So this means it's filtered, but then it's secreted, so we add more. Okay, so these would be things that the body wants to get rid of. Okay, potassium is typically one of those. All drug metabolites are trying to clear the body of certain toxins with drugs. Okay, so the clinical application here is that pharmacists must know the renal clearance for a drug in order to determine the correct high dosage. Okay, or correct dosage. So if it's a very high renal clearance, then you need a higher dosage. Low renal clearance means you need a lower dosage because it'll stay in the blood for longer. All right, well, let's take a look at a couple practice examples here. So I'll help you guys through the first one, and then you can do the next two on your own. So again, here's our equation. Renal clearance equals UV over P. Okay, so if we just put these in, we got our 250 milligrams per milliliter times 2 milliliters per minute. Divide all of that by our P, which is 4 milligrams per milliliter. Okay, so 250 times 2 is 500. Divide that by 4 is 125. Okay, and then the units here, we're going to see are the milligrams. We have a milligram on the top here, and we have a milligram on the bottom, so those are going to cancel out. Right here we have a milliliter on the bottom, milliliter on the top. Those are going to cancel out. So what we're left with is mils per minute. Okay, so we're left with 125 mils per minute. Okay, and that's equal to GFR, right? So if it equals GFR, then we would say that it's freely filtered, not secreted, not reabsorbed. So this would be an example of A. Okay, so I'm going to let you work through this substance 2 as well as substance 3. Okay, and you guys can answer those ones on your own. And you'll definitely have a couple of those for the TBL, IRAT, TRAT. So make sure you're ready to do those calculations. Okay, so the other part of this will be acid-base balance. Okay, so not just water balance, but acid-base balance is a big role of the kidneys as well as the lungs. So we're going to talk about those briefly here, but a little more of the kidneys role since we've already talked about the lungs role. Okay, so why does acid-base balance matter? First of all, because enzyme function is sensitive to pH, as well proteins can denature in the wrong pH, and then ion solubility changes with different pH. So one example of a problem with this is bone can actually break down if blood gets too acidic. Okay, so a buffer system we know helps us to prevent major changes in fluid, just like we saw in the respiratory lab. Okay, and the components of it are always a weak acid and a weak base. Okay, so let's look at the most common example again. The major buffering system in our blood is this one, the bicarbonate buffering system. It's not the only one, but it's the most prominent. So, I think it says there, circle the weak acid, underline the weak base. What do you guys think? Remember, the acid's always in the middle, so we'll circle that weak acid, underline the weak base. Call this one carbonic acid. That's our weak acid, and bicarbonate is our weak base. Okay, so the classic examples we've gone through, starting all the way back to the first day of class last semester in Bio 130. If we add a base to a solution, the response of the buffering system is, well, first of all, the buffering system has to help us by adding protons. Okay, so that technically moves the equation to the right. Right, it's going to move it this way. Okay, and then that's going to make the pH go back down, back more acidic. Okay, if we add an acid to a solution, okay, the protons that we're adding with that acid bind to bicarbonate. Okay, and the response of the buffering system is we have to move the equation back to the left. Okay, and then the pH goes back up. It goes back to the left by that H binding to the bicarbonate, turns into carbonic acid, and we move that equation left. Okay, let's look at how the kidneys help us do this. So they use the very same mechanism, but just a little bit different. Okay, so the kidneys can help us in either one of two ways. They can help us get rid of hydrogen or bicarbonate, or they can help us conserve hydrogen or bicarbonate, depending on what's needed and depending on which cells in those kidney tubules are working. So those little tubules we've been talking about in the nephron, those are little tubes just lined with little cells, and those cells have roles to play in adding things to the urine and bringing things back. And so inside the kidney tubule cells, we have carbonic anhydrase. Okay, we have two different types of cells. The type A cells secrete hydrogen and reabsorb bicarbonate, and the type B cells do just the opposite. They bring back bicarbonate and secrete they bring back or reabsorb hydrogen, and they get rid of bicarbonate. Okay, so the type A cells are much more active, much more common, because urine's usually acidic, because most of the metabolic waste products are acidic. So we're usually trying to increase pH of the body to make sure it doesn't get too acidic. Okay, so the steps of this in one of these cells is, first of all, we're talking about type A cells here. Okay, but I don't have a slide like this for the type B cells, but it would be just kind of the reverse of the reactions. Okay, so with the type A cells, carbonic anhydrase, the enzyme in the kidney tubule cells, helps us to combine CO2 and water. Okay, and that turns into carbonic acid. Carbonic acid then breaks down into hydrogen and bicarbonate. Okay, the cells get rid of that hydrogen, they pump that into the urine. Okay, and they can do that either via primary active transport using ATP or secondary active transport with the help of sodium movement. Okay, so we get rid of it that way, and then the bicarbonate is reabsorbed into the blood via exchange with chlorine. Okay, so this next slide shows how that works with an image. I'm not going to fill in these numbers for you here, but I want you to go to this figure in your book, figure 2511, fill in all the steps here with what's going on, and then decide whether this is a type A cell or a type B cell. And this doesn't show the co-transport of hydrogen, or it doesn't show the exchange with chloride, but you can see those written in here. Okay, so go ahead and fill those in. Make sure you understand these steps. It's a very important part of what's going on here. Okay, so we've already talked about how the respiratory system is involved in pH control. When CO2 accumulates, that decreases the pH of body fluids because of that bicarbonate system. Okay, this lower pH stimulates increased ventilation. Increased ventilation helps us get rid of that CO2, and that increases pH in the body fluid. Okay, so that's how that's involved. So now we're going to walk through a few examples of really 4 different things: respiratory acidosis, respiratory alkalosis, and then we'll talk about metabolic acidosis and metabolic alkalosis. So it's important that you understand the definition of all 4 of these, the causes, and then how does the body compensate for these. Okay, so the definition of acidosis is a pH of 7.35 or lower. And if it's respiratory acidosis, then it's because we're not breathing enough. Okay, hypoventilation, not breathing enough, would lead to increased CO2 levels, right? That would lead to, and then those could eventually combine with water, eventually turn back into hydrogen, right? And that would increase that would decrease our pH. Okay, so some causes of this are breathing problems. Emphysema causes this, and then too many narcotics cause you to slow down your breathing. This can lead to acidosis. So we correct this by increasing urine output of hydrogen. Okay, we don't correct this. We can't say we correct this by just telling the patient to breathe more, because that's the problem, right? The problem is breathing not enough. So yeah, it'd be great if we could just say breathe more, but that's not the way the body accounts for this, because there's a pathology involving the breathing. So the way that the body accounts for this is secretion of hydrogen via the urine. Okay, so it's respiratory acidosis. Metabolic acidosis, again, is that lower pH, lower than 7.35, and it's because we're generating too many hydrogen ions. Okay, so why are we doing that? Well, one example is ketone bodies. Okay, so when somebody has diabetes and their body can't get the glucose into the cells, the body has to start going to other sources of energy. And so the liver can make something called ketone bodies, which is a form of a fat, but they're very acidic and they release hydrogen. So that can lead to metabolic acidosis. And this also happens during starvation, both due to the liver forming ketone bodies, and that, I just explained that. Another example, which shouldn't really be under starvation, this should actually be a back one, is severe diarrhea. Diarrhea would cause metabolic acidosis because all of the bicarbonate-rich juices that come out of the pancreas, right? So pancreatic juices are bicarbonate-rich, so if we have diarrhea, we lose all that bicarb, which results in excess hydrogen. Okay, so how do we fix this problem? The body compensates for this by breathing more, right? If we breathe more, we blow off that CO2, and that's going to raise our pH back up. We can also get rid of hydrogen in the urine via the kidneys. Okay, so note how the metabolic acidosis is corrected for by both the respiratory system and the urinary system, but the respiratory acidosis can only be corrected for by the urinary system because we can't just tell them to start breathing more if the breathing is the problem. Okay, now the two alkalosis problems. Respiratory alkalosis. Alkalosis is defined as a pH of 7.45 or higher. Respiratory alkalosis is too much breathing, hyperventilation. So caused by anxiety, high altitude, we've already talked about that a little bit. So we fix this one by decreasing urine output of hydrogen and increasing the reabsorption of hydrogen. All right, so we bring more hydrogen back. Again, this is not corrected for by the lungs because the lungs are the problem, only corrected for by the urinary system. And then lastly, metabolic alkalosis. Some diuretics will cause this just by having to urinate so much, you lose too much hydrogen. And then vomiting. Okay, so again, just like diarrhea could cause acidosis because we're losing bicarbonate, what do we have in our stomach that we vomit up? Lots of hydrogen, right? So if we have lots of hydrogen, we lose our stomach acid with vomiting, and that's gonna decrease our hydrogen ion concentration, cause alkalosis. Okay, so we compensate for this one via both the kidneys, decreasing urine output of hydrogen, increasing reabsorption of hydrogen, and we can also decrease ventilation, slow down our ventilation to hold on to more CO2 and make more hydrogen. All right, guys, that's it. We will see you soon.